Good morning, everybody. On behalf of the Nutrition Society of India Mumbai Chapter, myself, Dr. Subhadra Mandalika, convener of the chapter, wish each one of you who have registered and joined us today for this webinar a very happy Diwali. As you all know, Nutrition Society of India is one of the most reputed association of nutrition professionals, programmers, and policy makers from India and abroad. The NSI works towards various aims that would benefit nutrition students, academicians, researchers, and community at large. Our chapter, that is NSI Mumbai Chapter, is one of the most active zonal chapters. We are working very sincerely towards fulfilling various objectives of our headquarters through our community outreach programs, disseminating the scientific information through webinars so far, and also our very, very valuable publications which are available on our website. We also collaborate with reputed NGOs and organize various community outreach programs online. And these are just two very good examples that have been conducted in this year. Our programs and the quality of information that we provide has been very well appreciated both from within and outside India, which is evident from the ever-increasing followers of our social handles and also the increasing number of views of our webinars that are continuously available on our YouTube handle. We are very, very thankful to all the participants who register for our programs in overwhelming numbers and keep encouraging us and motivating us towards planning many more valuable programs like today. As you all know, World Mental Health Day is celebrated usually on 10th of October. Today, we are commemorating the World Mental Health Day of 2021, the theme of which is Mental Health Care for All. Let's make it a reality. Amidst alarming statistics of mental health disorders, the issue of mental health has been recognized as a priority, and recently it has also been included in the Sustainable Developmental Goals. We all are very familiar with the current scenario that the COVID-19 pandemic disturbed everybody on earth. It has certainly disturbed the physical health of several people, but mental health of each and every one. Beyond pandemic, also, there are several mental health issues which are not very much discussed in public. Somehow, mental health has taken a backseat, probably because people are not willing to discuss about it openly and go out for treatment of that or prevention of those issues. As nutritionists, we are more interested in prevention of any kind of disorder or disease. And that is where the inseparable link of food and mood comes into light. So there is, of course, paucity of data in this area, but there are eminent scientists and researchers who are working very hard to generate valuable information in this field. To update the knowledge of those nutritionists who already are working in this area and to make other nutritionists aware of the possibilities of nutrition to be a preventive measure in mental health disorders, we have planned today's program. We are very proud of collaborating with Food and Mood Center Impact, Deakin University, Australia, to organize this workshop, which is having two different sessions today as well as on the 20th. Our association with Food and Mood Center began with Dr. Tithiana Rocks, who has been a very valuable expert twice on our programs. And she has contributed immensely to the knowledge of all the nutritionists and various participants across the globe for those sessions. It's indeed a very, very interesting area to know more and more about. Dr. Tithiana is a postdoctoral research fellow, head of translational and educational stream at the Food and Mood Center Impact, Deakin University, Australia. I have the proud privilege of introducing the two experts who are going to conduct today's session to each one of you. Dr. Rocks has received PhD from University of Sunshine Coast. She is also an accredited practicing dietitian. Dr. Rocks is extensively involved in education and training of professionals and community in nutritional psychiatry. This word has really impressed us a lot. Last year, when we were actually browsing through to understand more about the nutrition perspective of psychiatry. And we are indeed very fortunate to have come across Dr. Rocks, and now we developed a bond with you, Dr. Tithiana. And she is a much sought after speaker at various academic and professional events. And of course, we are one of them. And she leads several research projects exploring the relationship between diet and mental health. Not only that, dear participants, her interest extends even to gut health. So she actually very beautifully brings about the link between diet from all other aspects, gut health, and also the mental health, which is very, very interesting. And she is involved in investigations in individuals with eating disorders and post-traumatic stress disorders, which is very interesting and very important for all of us to understand more about. And currently, Dr. Tithiana is leading an internationally recognized free online course on food and mood, improving mental health through diet and nutrition, which has more than 69,000 enrollees globally. And I want all the participants to avail of this course. And today, this workshop which we are organizing, it will definitely introduce you to the main aim of Food and Mood Center. And you will definitely be benefited by enrolling for this particular course as well. Now, I move ahead introducing you to our next speaker, Dr. Edwin O'Neill, an associate professor, director of Heart and Mind Research Impact, and a deputy director of Food and Mood Center. Dr. Edwin has completed her doctoral training at the School of Public Health and Preventive Medicine, Monash University, and she has received international postdoctoral training at Stanford University. She is a behavioral scientist who has been researching the link between mental and cardiovascular health over a decade. Dr. Edwin, it is very interesting to know that how you connect the nutrition, mental health, and non-communicable diseases, one of the highly prevalent non-communicable diseases, that is CVD. So her work currently is revolving around understanding the links between these three aspects. A key part of her work is investigating the role of the lifestyle that plays in the onset as well as outcome of depression and CVD, both respectively in relation to each other and when they co-occur. I really love this expression of your work, like the way how you communicated your work so briefly but very, very meaningfully. She works with the team at the Food and Mood Center to apply learning from cardiovascular disease and other areas of chronic disease prevention and management to psychiatry. She is also a qualified family violence practitioner. This is indeed very interesting to all of us, Dr. Edwin. It's very, very interesting. Like, we would like to know more about like what kind of work is involved in this. This is something like a new area for all of us. And she is an extensive researcher that is very evident from the above details. So she has over 100 publications in reputed scientific journals. We have the proud privilege to go through some of her reputed articles in the journals. And with this, I welcome Dr. Tithiana, Dr. Edwin to conduct this session. I now hand over the session to Dr. Tithiana to conduct the proceedings. Dr. Tithiana, over to you.
Thank you very much, Dr. Subhadra, and thank you for having me here today. I am very excited and very privileged to talk to you about food and mood. So I'll start my presentation. Everyone can see my slides, all good?
Yes.
Excellent. I just move stuff around, fantastic. All right, so to start, I would like to wish everyone happy Diwali. And I would also like to acknowledge the traditional owners of the land from which I'm meeting you here today. And for me, it's Vadavarun people of the Kulin Nation. And I would like to pay my respect to their elders, past and present. I also like to extend that respect to all First Nations people here with us today. So I'm gonna start my presentation on the role of diet in mental health in youth and opportunities for intervention from a brief introduction of our Food and Mood Center. I appreciate the invitation, and I thought it's gonna be a great idea to show you all where we're coming from. So our Food and Mood Center is part of the larger Impact Institute. We sit under School of Medicine at the Deakin University, Australia. At our center, we pioneer research in nutritional psychiatry. Our center is reasonably new. It's only about 5 years old. But in these 5 years, we covered a fair bit of ground and grew substantially from a few researchers to a multidisciplinary team of about 50 researchers and practitioners. This is photos of some of us. We are led by Professor Felice Jaka and Associate Professor Adrian O'Neill, who's going to be a second speaker in this session. As I mentioned before, our team is working on the development of new nutrition-focused preventative strategies and treatment options for mental and brain disorders. We have a fairly broad take on diet and mental health, looking at the relationship from nutrition and neurodevelopment in early life, right to healthy aging by linking diet to cognitive decline and neurodegeneration. Along with mental health, we can see the physical health, particularly gut health, and I will be talking about that next week on the 20th of November. We develop research in gut microbiota and see how a gut microbiota might contribute to our understanding of mental health disorders, their prevention and their treatment. It's quite an interesting pathway, so that's why we're all fascinated by gut microbiota. But of course, we look at human behavior, physical activities, overall lifestyle practices, and Associate Professor Adrian O'Neill will cover that in her presentation. Our center is quite unique in nutritional psychiatry focus, and we support critical importance of diet in psychiatry. So today is two-part presentation. First is my part, but unfortunately today I'm just stepping in for one of my colleagues, Megan Hockey, who helped me with developing of these slides. She's a clinical dietitian and researcher. Unfortunately, she can't be here with us today. So do forgive me if I'm not gonna be, as sharp as I could be, because it's not exactly my topic, but I'm very happy to discuss with you mental health in youth and application of diet in treatment and prevention of mental health disorders in this population. I will start with some statistic and evidence. I'll discuss some guidelines and go through recommendations for diet in this specific age group, and outline some practical strategies for implementation of dietary approach to prevent and treat poor mental health in young people. It's important to remember, and we're all aware of this, but I might just go ahead and remind everyone that childhood and adolescence are critical windows of development and stages of life for mental health. This is time of very rapid growth and maturation. That's when we rapidly grow, mature, our brain develops, and that's quite important for the rest of our life. When I talk about adolescence, I mean that period of life between 10 and 19 years of age, when children transition from being kids to being young adults. Globally, adolescence is a very large population. 1 in 6 in the world is actually adolescent. At this age, adolescents acquire cognitive and social and emotional skills that shape their future mental health. It's also a very vulnerable period of life. Health-related behaviors that drive the major chronic degenerative diseases start or reinforce during this time. During this time, also many psychiatric conditions emerge for the very first time. Common mental health disorders such as depression and anxiety often arise in our earlier years and can be long-lasting. We understand that half of all mental disorders emerge by the age of 14. Globally, up to 20% of adolescents are estimated to live with mental health disorder, with most common being depression and anxiety. That's why they call common mental health disorders. Unfortunately, many of the kids suffer in silence and don't have access or don't seek access to help and treatment. 40% of adults with depression experience their first episode before 18 years of age, meaning that the consequences of not addressing mental health during adolescence extends into adulthood. We understand the development of depression during adolescence represents a lifelong course of that disorder of depression. Consequently, given that large number of adolescents within our global population, remember 1 in 6, and the high proportion of mental health disorders in this group, adolescence is a critical period for mental health intervention. This diagram reinforces my message by showing that in fact, health burden of most mental disorders, but particularly depressive disorders and anxiety, peak just before that transition into adulthood, about late teens to early 20s, about here. As you can see, most of mental health issues peak here. Dr. Subhadra also mentioned how extensively the COVID-19 pandemic influenced our mental health. Recent meta-analysis of more than 80,000 youth suggests that youth mental health difficulties during the course of pandemic have likely doubled. It's impacted all of us, but for young people, this period has been particularly tough, with 1 in 4 experiencing clinically elevated depressive symptoms, 1 in 5 have anxiety symptoms. This is likely due to increased social isolation, missed milestones. Lots of kids had to stay at home, study from home. They miss out on participation in other activities with friends. They experience constant school closures, quarantine orders, increased family stress, unfortunately, decreased peer interaction, as well as that reduction in contact with support structures such as their teachers and coaches and mentors and any other groups they might have outside home, which is very important at that age. Poor mental health have a significant impact on young people. It decreases their quality of life. It impacts learning and academic outcomes. It reduces social functioning. It can lead to self-harm and suicidal behavior. And often it linked to adverse outcomes in later life, such as poor social and physical functioning, unemployment, poor physical health. When it's come to treatment to mental health disorders, particularly depression in youth, early identification is absolutely critical. We see again and again that sooner we address mental health issues in kids, the better prognosis is, the better outcomes might be. Most depressive disorders are managed with either pharmacological, so medication treatment, or psychotherapy, so psychological treatment. However, these two approaches, although regular and working for many people, do have their limitations and barriers. For example, wait times. I know in Australia, wait times increased dramatically when people seeking treatment for mental health issues. What also problematic with pharmacological and psychotherapy treatment or psychotherapy-based treatment, it's that these don't actually address comorbid presentation we quite often see in mental health disorders. In fact, 80% of people who have mental health issues have also comorbid physical issues, and using medication does not address this. Given the high burden of mental health issues and high prevalence of mental health issues, there's urgent need to explore alternative pathways and options that target modifiable risk factors for mental health disorders. One of them is lifestyle and diet. So lifestyle medicine, it refers to low-cost, low-risk interventions that focus on factors such as physical activity, sleep, and nutrition. And increasingly, lifestyle medicine seen as an important part of mental health care. This model is termed biopsychosocial lifestyle model. It includes nutrition, physical activity, sleep, smoking cessation, and reduction of substance abuse and alcohol consumption, all of which have been shown to affect the development and clinical management of many mental health disorders, particularly depression. In adolescence, lifestyle interventions, including dietary changes, might be a promising candidate to help in treatment and prevention. What is highly beneficial in lifestyle approach, that it sets youth for life and might also reduce the risk of developing de novo psychological disorders and reduce chances of reoccurrence of some mental health issues. In the last decade, we've seen an increased interest in research and in practice on the impact of lifestyle behaviors have on our mental health outcomes. In the last decade, we also established diet as a modifiable risk factor for prevention and treatment of depression in adults. Specifically in adults, this meta-analysis showing that, for example, adhering to a healthy diet, in particular, this meta-analysis, first one of observational study, showed that adhering to traditional Mediterranean diet, which is characterized by high intakes of whole plant foods such as fruit, vegetables, whole grains, legumes, nuts, seeds, olive oil, and moderate amounts of lean red meat and dairy, was associated with reduced risk of depression, of developing depression. On average, that risk is reduced by about 30%. What is interesting about it, that we see studies from all over the world in different populations which look at different diets, and they consistently show similar outcomes. It doesn't have to be Mediterranean diet. It's any diet which is high on this whole plant-based foods, such as fruit, vegetables, whole grains, and legumes, and very low in the intakes of ultra-processed foods or Western-style foods. consistently associated with better mental health outcomes. Meta-analysis, which involved 45,000 participants, also showed us that dietary interventions are able to significantly reduce depressive symptoms. Unfortunately, this was done in adults. In children and youth, we have less evidence for this, simply because I think this population is quite challenging to conduct interventions in. Nevertheless, adolescents provide an important window for prevention and intervention when it's come to lifestyle in general and diet in particular. Currently, nutrition intake of young people is quite poor. This report from United Nations Children Fund, or UNICEF, shows that although dietary habits vary across country income groups, universally, these are not great. This figure presents proportion of adolescents by country income group, so low, lower middle, upper middle, and high, and intake of fruit, vegetables, sugar-sweetened beverages, and fast food. You can see that there's not much difference between, say, low and higher income countries. The nutritional intake is universally poor. Globally, only 34% consume fruit and 21% consume vegetables. Globally, 34% of kids consume fruit and 21% consume vegetables less than once a day. So not enough fruit and vegetables. Unfortunately, 42% drink sugar-sweetened beverages, carbonated soft drinks, at least once a day. And again, it's everywhere in the world. Just under half, about 46%, consume fast food at least once a week. When it's come to skipping meals and under-eating, adolescent girls, particularly girls from low-income countries and rural areas in lower to low middle-income countries, eat fewer than 3 meals a day, and most don't eat breakfast. We know that adolescence is also a period of considerable change in dietary intake patterns. We see that during this time, we notice more frequent snacking, so kids are always hungry and young people always hungry. They skip meals, but they insist on snacking. They consume and increase meals away from home, so that growing independence and their business at school, some of them starting working away from home. So more and more they're consuming food away from that family table where we can have some kind of impact or influence on what they're actually eating. We also see that teenagers, adolescents usually consume large amounts of unhealthy food, which comes from snacking. And because they insist on independence over eating choices, it becomes more and more challenging to actually keep an eye and keep a healthy behaviors going. Yet adolescents' food habits are important determinants of not just present, but also their future health, their mental health, and their physical health. Food behaviors which develop during adolescence last into adulthood. They contribute to a number of health problems, including underweight or overweight, metabolic syndrome, and other non-communicable disorders such as diabetes, and also to a number of cancers. These disorders are related to mental and cognitive health. I've mentioned before that this time of life is marked by a rapid development. And we see that current food behaviors also in kids also might impact their brain development, in youth and later in life, particularly that part of brain that is linked to our mood and cognition and memory and learning, our hippocampus. We know that there's a clear link between hippocampus and mood, particularly in adults. We have few studies showing us that diet or individuals who consume Western style diet, which is high in ultra processed foods, such as fried foods or sugar sweetened beverages. So these individuals usually have smaller hippocampal volume than those who consume more higher quality diet, Mediterranean style diet, which is high in plants and non-processed foods. It's interesting that research also shows us that these associations stand time as well. So people who consistently consume better quality of diet their brain seem to age a little bit better than of those who don't eat well. In children, we don't have too many studies, but at least one study showed that higher fat consumption was linked to decreased left hippocampal volume in kids. There was no association found between other type of food or Western style diet or higher sugar intake. So basically, we don't know enough what's happening in food, but in children, but we do understand that in adolescence, academic achievements have a significant influence on their future health and social outcomes. We know that quite often school years set our kids for life. When it's come to diet, the dietary outcomes most commonly reported to have positive associations with academic achievements include breakfast consumption, so kids need to have their breakfast, and diet quality. Not surprisingly, we see negative associations between fast food consumption and academic performance as well. We have few cohort studies which link dietary intake directly to mental health outcomes in youth. Both of the studies, which I present in the next two slides, are conducted by our research group in collaborations with our colleagues. Both show quite interesting independent associations between lower intake of healthy food and higher intake of unhealthy food and higher depressed moods in adolescence. This first study was conducted in Australia in children 10 to 14 years old and showed these independent associations between lowest intake of healthy food and highest scores for low mood and highest intake of unhealthy food and equally higher scores for low mood. Next, slightly larger study in slightly older kids also show these associations. Here, we link dietary intake to quality of life. What we saw again, that highest intake of unhealthy food and highest intake of healthy food were independently linked to quality of life. Which is quite interesting because when you think about during that age, kids quite often dependent on their social structures, on school, on their life with friends and family. But these two studies show these associations between food and mental and quality of life outcomes in kids is independent. We also have a couple meta-analyses which show again similar observations, consistent trend between diet quality and better mental health outcomes in children. First systematic review was led by Associate Professor Adriana Mills, so you can ask her all the questions about this study, but it did show those associations: better food, better mental health outcomes. Second meta-analysis, it's more a recent meta-analysis published in 2021. It's also used observational studies. 39 studies were included in that work, and it's reported small but significant inverse association between healthy dietary patterns characterized by high intake of nutrient-dense foods and low intake of ultra-processed foods, and depressive symptoms in children and adolescents. At the same time, unhealthy dietary patterns, high in processed foods, sugars, refined carbohydrates, and saturated fats were found to be independently linked with increased depressive symptoms. We do need more studies to understand how exactly can we do that and what exactly components of diet are actually linked to mental health outcomes in young. To date, we only have one study which looked at younger population. One of the interventional studies which tried to change diet to impact mental health outcomes. That was a 3-week parallel group, single blind, randomized controlled trial conducted in Australia. 100 young adults, 17 to 35 years old, majority of them were close to 17 than to 35, who habitually consume poor diet, were randomly allocated to a very brief 3-week diet intervention, or they were allowed to continue with their habitual diet, and they were control group. So 38 people completed that intervention in each group. Those in the diet group receive instructions from a registered dietitian through video. So they did not even see dietitian live. It was all done through video. So 13-minute videos. They also received a sample meal plan, recipes, and food hampers to help them with behavioral change. After 3 weeks, diet group significantly reduced their depression symptoms compared to control group. It was interesting that this all what it took, it just few videos with instructions about better eating. In this study, participants were instructed to increase their intake of vegetables to 5 servings a day, fruits to 2 to 3 servings a day, whole grain cereals to at least 3 servings per day, proteins such as lean meat, poultry, eggs, tofu, and legumes to 3 serves a day, unsweetened dairy to 3 serves daily, fish 3 serves per week, and nuts and seeds 3 tablespoons per day, as well as olive oil. Recommendations were for spices, to include spices to increase flavor and to make the diet a little bit more interesting. Conversely, they were instructed to decrease the consumption of refined carbohydrates, sugar, and fatty and other ultra-processed foods, such as processed meats and soft drinks. So it's quite interesting, just 3 weeks, and it's actually worked for younger people. So when it's come to use, we have quite a few opportunities for intervention. We can work on individualized approach. We can also target children through schools, because school, of course, present fantastic opportunities, platforms for interventions. And we also can work through changing of policies and government-related programs. Currently, there's no really clinical practice guidelines for treatment of mental health disorders in children through diet. We know that in adults, recently, Royal Australian and New Zealand College of Psychiatry published guidelines which recommend diet along with other lifestyle changes as #1 actionable step in treatment of depression in adults. In children, we only have guidelines from National Institute for Health and Care Excellence in UK, which recommend for children or young people with depression to offer them advice about nutrition and benefits of balanced diet. But we need more studies to actually devise guidelines which will specifically target children and adolescents. In general, nutrition recommendations for depression include a diverse range of high fiber plant-based foods such as whole grains, fruits, vegetables, and legumes. We also like for people to include good quality fats such as extra virgin olive oil or other culturally appropriate plant-based oils, as well as oily fish, nuts, and seeds. We recommend to include moderate amount of lean red meat and unsweetened dairy products. And of course, limit discretionary foods or those ultra-processed foods, which we know kids and young adults eat a lot. When it's come to adolescence, there are few key nutrients we of course need to consider, because it's such an important period for growth and maturation. We need to make sure that kids actually have enough energy and protein to support that growth. Quite often children, particularly girls, become very low on iron during their teenage years. And we need iron, of course, to support that forever expanding blood volume in the growing body. We understand that children need enough of calcium and vitamin D to support their bone mass and also to peak bone mass. We know that peak bone mass, the higher it is in young adulthood, the better their prospect is when it's come to bone health later in life. So it's really quite important to take and to treat each kid individually to understand, or each young person individually to understand their specific requirements. There's no single best practice model for delivering dietetic care or nutrition care to young people or to any other people for that matter, because we're of course always guided by individual needs. But in general, it's quite important to be empathetic, respectful, and non-judgmental when it's come to young adults and all the children. So respect is one of the most important factors here. We need to understand confidentiality and consent issues, because that's an age when quite often children would like to become independent of their parents. Consent and privacy needs to be discussed. We need to be vigilant of boundaries. Again, it's very important for us as practitioners to protect ourselves with the boundaries and to provide safe environment for children and young adults to be able to build that rapport, to be able to understand their needs. We also need to understand the link between physical and emotional well-being and being able to explain that to kids, because that's going to help us to move away from this topic when we link diet to, say, physical outcomes or shape of their bodies, and focus more on their emotional and psychological well-being. We also need to understand that family, school, and peers are always going to take kind of precedent always gonna take more important roles. So we can't work against them, we need to work with them. Good communication skills for working with children is quite important. For example, I think that I'm quite funny when it's come to my communication skills, but my kids always think different. So what we can do is try. So to increase motivation in your young clients or in your young consumers and customers, it really depends on their age. We see that for younger kids, family and peers and role models such as parents or heroic figures or sport figures might work quite well, along with rewards, of course, non-food-based rewards. That gentle exposure to good nutrition is quite important for younger kids too. We can't put pressure, we can't tell kids to eat, say, vegetables and then they can have sweets. That's really bad idea. In all the children and young adults, we can really start to harvest that interest in health and understanding the links between diet and mental health. We can work with their values. For example, we see that in children and young adults who are, say, quite into their sport, they like to play sport, we can explain to them how better diet quality will support their sporting achievements. And of course, we need to encourage this autonomous motivation in children, because prescriptive diet will not work. As soon as they gain their independence, they will do whatever they want. So the challenge is to encourage that autonomous motivation. We discussed before that adolescence is that period when we see transition from childhood to adulthood in many aspects of life, including food. So food choices at this age impacted by numerous factors such as convenience and habits, family and peer influences, attempts for weight control. We usually see that unfortunately girls, when they grow in, their body growing, they like to make themselves smaller through food. And boys, on another hand, like to make themselves bigger through food. So that's something to remember. Of course, their beliefs and dietary culture around them, whatever they might get exposed to on social media, will impact their choices. And of course, taste preferences. So all of these have to be taken into consideration when we're trying to help our young people. Few of aspects of food behavior are particularly related to adolescence. Those 4 features we see in almost all the kids and younger adults. They skip meals, they eat away from home, they drink a lot of sugar-sweetened beverages, and they snack. So we need to educate them on the importance of regular meals. It's important for their growing bodies, but also for their mind. Remember how I was talking before that, for example, consumption of breakfast is consistently associated with better academic outcomes. So we need to encourage them to eat something for breakfast. Any breakfast is better than no breakfast. That's one thing to remember. We need to also keep in mind that adolescents love to eat away from home. 1/3 of all their meals actually eaten away from home. So we need to educate them on convenient, healthy options, because if they think that McDonald's or KFC or any other highly processed foods are convenient, that's what they're going to be eating. If it's trendy, that's what they're going to be eating. So we need to educate them away from those choices. Sugar sweetened beverages, they drink a lot of soft drinks. So again, understanding and explaining what in those sugar sweetened beverages, how they might impact their mental health, becomes quite important. Role modeling for parents, also important. If kids grew up seeing their parents drinking soft drinks, they will think that that's quite okay. So we need to encourage alternatives such as, simple water. Simple, clean, fresh water is always better. For children, milk is also an important source of fluids. Snacking, another important part. So over 25% of all adolescent energy intake comes from snacks. So anyone who have kids or know kids know that they would prefer to snack than to sit down and eat proper meals. So considering healthy snacking is quite important, and explaining to them what could be consumed for snacking, for healthy snacking. As I mentioned before, the approach to changing dietary behaviors is highly individualized. Assessing and understanding barriers and challenges to implementing a healthier diet is absolutely essential for us to develop those recommendations which will support positive and long-lasting dietary change. This process really needs to include young people in decision-making and consider their skills, their resources, and of course involve their social support, such as parents. We understand that environment is usually quite a barrier when it's come to healthier eating. So we need to work on recommendations for creating a healthy food environment at home or anywhere they spend a lot of time. So we need to encourage family to stock their fridges and pantries if they have resources with healthier foods. Motivation, including motivational interviewing and working on their values. Remember how I was talking for younger kids, role models or superheroes, my work for all the children, talking about their health, talking about their cognitive and academic performance could work as well. Knowledge and skills, unfortunately, we have a lot of children who grow up without basic knowledge and skills when it's come to food. So exposing them to understanding and building basic skills around food is quite important. We also understand with the taste preferences, sometimes children and young adults need to consistent exposure to food to actually like that or try that in the different varieties. There's also, of course, cost of food. So, and if there's some government programs which can help support a better diet in children, we need to inform kids and their parents about those programs and educate them on affordable food options, such as buying local food from local farmers, which is always a cheaper option. And educate them on healthy, convenient meal ideas. We can't just say to children, don't eat the ultra-processed or takeaway foods. We need to let them know what is okay to eat. This age, of course, is very important for making things right around diet, because eating disorders are commonly present as comorbid disorders with depression. We saw the increase of prevalence in eating disorders during COVID pandemic. For example, here in Australia, in Melbourne, Australia, there was 63% increase in presentation of adolescents with severe eating disorders into specialist pediatric services. There's different reasons for this. What we need to remember when we talk about diet with youth, with adolescents, we need to have that non-threatening approach and move away from, say, focusing on their bodies and physical outcomes and have that more inclusive message of mental health outcomes. Some red flags for you to consider: sudden weight loss. They don't need to be underweight for us to start worry when children and young adults start losing weight. If they eat alone or eat in their room away from everyone, if they have specific rituals around food and they might start eating white food but not red food. If they cooking for other people but don't eat themselves or just push food around their plate, that's something for parents, to include parents to kind of watch over their children. If they have frequent exercise or weighing themselves or consuming too much water, all of these might indicate that children start developing some disordered behaviors around food, which of course quite important to avoid. With this, we can really work with children to explain that bodies exist in different shapes and sizes. So it's okay to have any type of body, and every body can be a healthy body. It's good to focus on enjoyment of food and talk about what we can eat instead of, say, focusing on what we can't eat all the time. It's important to encourage diversity around food, avoid some restrictions or very prescriptive style of treatment around food. We definitely need to make sure that we don't encourage cutting out any food groups at all. Definitely avoid that all or nothing approach, and keep explaining and keep encouraging children to have that better relationship with food. Understand that food is just one aspect of life. It can be enjoyable, it can be supportive for our mental and physical health. So overall, take-home message. So we understand that, of course, diet along with other lifestyle practices is absolute foundational for mental health well-being in adolescence. And what's important to remember, that diet and nutrition is an absolute foundation for later in life as well. So promotion of healthy diet should be encouraged at that age. And we understand that it will help to prevent development of depression, and it will also set our children with good habits for life. So simple, although there's no specific recommendations, we understand that whole foods, low intake of ultra-processed foods, and high intake of plant-based foods such as whole grains, fruit, vegetables, and enough protein and energy for healthy growing bodies. That's what we need at that age. Thank you very much for listening to me, and I'm very pleased now to pass on to my colleague and dear friend, Associate Professor Adrian O'Neill, who will take over.
Sorry. My apologies.
You good to share?
Yep. Is that, can you see that?
Hang on. Just give me, yep. I can see, no, hang on. I can see your file, but not the actual presentation.
Oh.
Try again.
Sorry.
I can mention while you're getting ready that, of course, we're going to have sufficient time for all the questions and answers after Adrian's presentation. So please feel free to type your questions into chat and we will discuss them. So I can see your notes here. Is that what you meant to share? So I see a presenter screen. Okay.
No, I'm sorry. I'm not sure why it's not working.
That's okay. We can have a chat, and I can have a chat with people while you getting ready. That
better?
sounds like right. Yep, definitely. Okay, I'm handing over to you.
My apologies for that. I'm not quite sure what happened there. Everything worked well during rehearsal, but in any case, it's my absolute pleasure to be with you today. Thank you so much for a fantastic presentation, Dr. Rox. It's a privilege to now take the reins. I'd also like to thank the organising committee and Dr. Subhadra for inviting me to present today. I would also like to wish everyone a happy Diwali and hope that you had fantastic celebrations. I would like to open my presentation by acknowledging the traditional First Nations custodians of the land on which I'm meeting from Melbourne, Australia, the Wurundjeri people of the Kulin Nation, and to pay my respects to their elders, past, present, and emerging. Okay, so I'm going to take a slightly different tact from Dr. Rox by way of broadening the discussion that was obviously very focused on youth and adolescence to adulthood. And in doing so, much of the focus of this presentation is going to be on physical health and the relationship between mental health, physical health, and then, of course, the role of diet and lifestyle within that. As Dr. Subhadra said at the beginning, I sort of wear two hats at Deakin University. One is as the director of the Heart and Mind research program, which is specifically looking at those links between mental and physical disorders. And of course, the deputy director of the Food and Mood Centre, where I can really start to incorporate a lot of the learnings over the last sort of 5 years of the centre's establishment. So I am not a dietitian or a nutritionist, so much of this presentation will be about where we're at in the evidence. But as Tithiana said, I'm very happy to stay around at the end and answer any questions that you might have. So this is a photo of myself and my sister when we visited beautiful India 15 years ago now. It's hard to believe that it's been that long, but I would love to be with you there today in person, but hopefully as borders open up again, it won't be too long and we will start to be able to travel the world and hopefully India and Mumbai is one of those stops. Thank you so much for initiating this collaboration, Dr. Subhadra, and with the Food and Mood Centre. So the learning objectives for this session, the first one is, of course, to discuss the role of mental health in individuals with mental illness. And I've included another one here, which is to consider how diet and lifestyle therapies for mental illness might reduce the chronic disease risk that is so elevated in individuals with mental disorders. But what I'm going to do now is just start by setting the global context for our work, which at the Food and Mood Centre really aims to improve population mental health by way of improving nutrition and dietary intake. So as Dr. Subhadra said at the beginning, depression is a leading cause of disability worldwide, and this was the case prior to COVID-19. But new analyses from the Global Burden of Disease Group have shown that cases of major depressive disorder have increased by 28% since the onset of the pandemic and 26% for anxiety disorders. So these graphs here are broken down by sex and age. And A is the prevalence of anxiety and B is the prevalence of major depressive disorder. And you can see that the blue shading is from before the pandemic and then the pink shading is rates after the pandemic. Now, pretty significant sort of changes there. Women appear to be more affected than men in terms of that change and that increase in case numbers or prevalence. Younger people, more so than older people, were also more relevant, which is precisely why Dr. Rox's presentation is so timely. And of course, those countries with the highest COVID-19 infection rates, and of course, the major, I guess, the policies around infection control, so reducing people's movement and things like lockdowns, demonstrated or had the greatest increases in the prevalence of depression and anxiety disorders. Now, if we just focus on India, there's been an increase of between 29 and 35% in major depressive disorder since 2020. It's around about 10 to 13% in Australia. For anxiety, it's more like 32 to 36%. In Australia, it's between 9 and 14. And the authors estimated that globally, COVID has resulted in an additional 53 million new cases or additional cases of depression and 76 million cases of anxiety. So what I'll be talking to today is posing the question, what are the health implications, the physical health implications of this trend? So we know that if an individual has a common mental disorder like depression and anxiety, or a severe mental illness like schizophrenia or bipolar, just the presence of those conditions alone elevates their risk of having a cardiometabolic condition like heart disease, diabetes, and vice versa. So it's a very intricate, very bidirectional relationship. And really worryingly, in Australia, 9 out of 10 of individuals who are living with a serious mental illness will die prematurely to a chronic condition like cardiovascular disease. And that is a trend that is, quite common across the world. But to put that into perspective, if that's 9 times out of 10 that an individual is dying through a cardiometabolic or chronic disease condition, compared to 1 out of 10 by suicide. So it is a very significant burden. And our colleague Megan Hockey, who obviously couldn't be here with us tonight, recently published a paper showing that even the prevalence of moderate levels of distress can heighten one's risk of dying early owing to one of these chronic conditions. So as we just saw in the previous presentation, the majority of common mental disorders occur before the age of 25 and in 50% of cases by the age of 14. So then if you think about over the life course that heart disease and stroke tends to manifest clinically much later in life, it does make sense from a temporal point of view that mental health is contributing to the onset of physical disorders in a way that makes it a genuine independent risk factor for the chronic diseases like heart disease. And we've generated our own data from our own region to show that for middle-aged women who have major depressive disorder, that the presence of that condition alone predicts them having a heart attack over an 18-year period. And others have shown that there's a similar level of risk for men as well. So really at the heart of my research program is to understand these bidirectional links between mental and cardiometabolic health, their shared pathways, their shared risk factors, and then of course how lifestyle interventions can mitigate negative outcomes. And look, the physiological mechanisms underpinning these relationships are incredibly complicated, but the fact that there are shared pathways and risk factors that do exist suggests that by treating one condition, that has the potential to improve the other. And something that Impact Institute at Deakin has been very interested in over the sort of last 15 to 20 years is the idea of depression as an inflammatory condition because indeed inflammation lies at the heart of many of these conditions that we're talking about. And so interventions that have anti-inflammatory properties, whether that's pharmacotherapies or other types, really have been a keen interest of ours. So naturally, the assumption is that if we can effectively treat depression, then we can prevent heart attacks and the onset of other physical health conditions, right? Well, the evidence is actually far from clear. And the last I reviewed the evidence, there was one notable study that had been able to demonstrate, using data from a well-known trial called the IMPACT trial, that treating depression could prevent the onset of a major coronary event. So this study was an RCT using a collaborative stepped care approach to treating depression. And that essentially means that there are a team of multidisciplinary, whether it's a nurse, social worker, psychiatrist, psychologist, in the treatment of depression. And so what they did as part of the secondary analysis was looked at whether or not those who were treated using this collaborative stepped care model versus a control condition were at reduced risk of having a cardiovascular event over the following 8-year period. And indeed, they found significant differences, which was very exciting because it was the first time this had been demonstrated. But actually, when you drill down further into the data, it was actually only significant for men, but not women. But one of the inherent problems with trying to answer this question is that it's really hard to do in a study because you need very, very large sample sizes and you need to follow those participants up over a very long period of time because, as I said earlier, depression and anxiety is most common in sort of early life, but you're not seeing the manifestation of the sort of cardiovascular and other conditions until, a mean age of 60 or 70 years old. So the next best thing is to ask whether treating depression has cardioprotective effects on cardiovascular risk markers like, say, lipid profile. And the short answer is, well, it depends. So this table might be a little bit hard to read, but essentially it's from a paper. It's a little bit old now, but it just essentially provides a nice overview of the sort of conventional pharmacotherapeutic treatments for depression and their positive, negative or neutral impacts. And you'll see there, just as a snapshot, that most are largely neutral, but as many of you would know, there are medications like tricyclics, for example, some SSRIs and some SNRIs, which may worsen lipid and metabolic profile. So the upshot is that conventional therapies may indeed, and really importantly, of course, help individuals to manage their depressive symptoms, which is critical for, reducing the inflammation, the oxidative stress, everything associated with, a chronic mental health condition. But for some, and certainly is the case most commonly with those with a severe or significant mental disorder, is that it can come at the expense of their cardiometabolic health. So this is, of course, where my role at the Food and Mood Centre and the work that we're all doing at the centre really comes into play. Could diet play a role in treating depression and mitigating that cardiovascular risk? Now, there's been some observational evidence, cross-sectional evidence, that inflammatory properties of a diet have the potential to mediate the relationship between depressive symptoms and cardiovascular risk. Now, those of you who might be familiar with the Dietary Inflammation Index is essentially looking at the composition of an individual's diet and describing it or characterising it as being pro or anti-inflammatory. And this study looked at that measure, the DII, and found that it it mediated the relationship between patient health questionnaire or PHQ-9 assessed depressive symptoms and cardiovascular risk using the Framingham risk score. Now, for women, we found, or the authors found, that it fully mediated this relationship. Now, of course, these are observational data, and more importantly, they are cross-sectional data, so we can't actually determine the timing, which comes first, and that temporal nature. So we have to look to the randomized controlled trial data to determine causation. So of the 3 randomized control trials that we're aware of, which evaluate or test that the role of dietary treatment in the management of depression, none have really looked at chronic disease risk change. And you'll hear more from Dr. Rox and our colleague Gina Howland next week as they delve into the data around those trials and provide much more detail. So really the next best thing we can do is to look at studies of dietary interventions in individuals who are perhaps at risk of chronic diseases and see what the impact of those has been on their mental health outcomes and their blood pressure and lipids, for example. So in 2015, Dr. Rochelle Opie and our team synthesised all of the RCTs in this area, which at that stage, it was before our Seminal Smiles trial or any of the 3 trials that have since been enacted. So there's very few studies that we were able to identify. And of the studies that did, there was 4 in participants who had either hypertension or dyslipidemia. 2 of those trials in patients with elevated depression used a Mediterranean style diet as an intervention, and they found that over a 12-week period compared to the control group, one of which was a low-fat diet, they found significant effects, improvements in psychological and mental health outcomes whilst lowering depression. So that sort of suggests that, I guess that provides sort of some evidence that there do appear to be benefits, but really all of those trials were very small and reasonably inconclusive. And then this happened. This is the PREDIMED trial, which I'm sure many of you are familiar with, the largest trial of its kind to look at whether the Mediterranean style diet can prevent cardiovascular disease in those at high risk. And the thing about this trial is that it was so large, recruiting and randomizing more than 4,000 individuals from the community, is that it allows us to try and answer some of these questions, because we can examine, the causal and the temporal role of diet in the relationship between depression and major cardiovascular events. So it was a 3-arm trial whereby there was a Mediterranean diet with extra virgin olive oil condition, Mediterranean style diet supplemented with nuts, or a low fat control condition, and that were followed up over the course of 3 years. Now, the primary finding of the study was that neither dietary intervention prevented cardiovascular incidents. There were trends towards that they were effective in reducing the number of strokes. But what I found really interesting was that for individuals who came into the trial with type 2 diabetes mellitus, who were randomized to receive the Mediterranean diet intervention supplemented by nuts, that prevented incident depression over the follow-up period by 41%. There were non-significant protective effects for stroke here as well. So to me, this again highlights just how closely mental and physical disorders are linked, and that dietary intervention really has an important potential to improve both conditions here. So since this seminal study, a Cochrane review has been published, I think it was 2019, providing an up-to-date account of evidence for the Mediterranean diet in both the primary and secondary prevention of cardiovascular disease. So I thought, fantastic, this has got, more than 12,000 participants, 30 trials, there's 7 ongoing. This will give us a wonderful opportunity to understand more about the role of diet in the relationship between depression and cardiovascular disease. But they didn't present any data on mental health. So again, it's owing to just a significant lack of data that's preventing us from answering a lot of the really important questions in this field. So what about beyond diet and nutrition interventions to look at the evidence around other lifestyle approaches? So as part of my PhD, I developed and evaluated a multi-target lifestyle program that included dietary improvement, physical activity, sleep, medication adherence, and smoking cessation to target those who are experiencing depression after they've had a heart attack. The 6 month, it was a telephone delivered intervention, which little did I know back in 2009 was going to be such an important mode of delivery in the current and post-pandemic environment. And what we found over the 6 month intervention period was those receiving this program versus those receiving a usual care control condition demonstrated significant reductions in depression post-intervention at 6 months. The effect size was sort of, I guess, a small effect size of 0.3. But when we looked at individuals who had a history of major depression before their heart attack, that doubled to a large effect size of 0.6. So again, it just sort of demonstrated that this approach seems to be really quite powerful for managing mental health. But of course, this was in individuals who had comorbid cardiovascular disease. Something that we also found was that the effects were maintained when we contacted them again 6 months later in the 12-month follow-up analysis. And yeah, so the reductions in those receiving treatment with the mood care program had maintained their reduction in depression. Unfortunately, the trial was too small to examine its effects on recurrent cardiovascular events. Again, it just speaks to the difficulty in sort of long-term follow-up and the sort of resource intensity of such a trial. But again, it got me thinking, I think, as we have, over the last 2 years, as we've been confronted with this rise in mental health disorders, and how we can best provide care using sort of dietary and lifestyle approaches, how we can do this in individuals who don't necessarily have a comorbid cardiovascular condition, but they are presenting with elevated distress and mental health conditions. So this is what we're currently doing as part of a large government-funded trial in Australia called the Curbing Anxiety and Depression with Lifestyle Medicine trial, the CALM trial. And the aim of this trial is to compare the extent to which a composite lifestyle program, which uses a Mediterranean-style diet and exercise intervention over 8 weeks, can improve depression and cardiovascular risk outcomes of individuals compared to those receiving standard psychotherapy. We're using a non-inferiority design, which will basically allow us to determine if one is as good as each other. So that's the key research question. And we are looking to recruit 184 individuals from our local and extended community across the state of Victoria, where we've currently randomised 104, so we're hoping to be finished by sort of mid next year. When they come into the program, they're randomised to receive either the calm lifestyle program or the psychotherapy program. Everything about these two conditions is matched in terms of resources, in terms of schedules, engagement tools. It's just the approach, the content, the discipline that is different. Both programs are delivered by Zoom in a group setting due to obviously the COVID-related lockdowns and things like that over an 8-week period. So that's 6 sessions. The CALM program is co-facilitated by an accredited practicing dietitian or nutritionist and an exercise physiologist, whereas the therapy control groups are facilitated by 2 psychologists who are using a cognitive behaviour therapy approach. Now, this is designed to be adjunctive treatment, so individuals can be on antidepressant or other medications. And the key outcomes that we are interested in, the primary outcome is mental health depression outcomes at 8 weeks, but we're also collecting cardiovascular risk profiles. So we've got bloods and stool samples and things as well. And we're also going to, and I think importantly, conduct an economic evaluation also. So here you'll see in the pink boxes, they're the program goals that we are using with participants to make it, we've tried to make it as understandable, I guess, and sort of like palatable, I guess you would say. And these are based on our previous work in lifestyle psychiatry, some of which Tithiana has mentioned through, you know, the observational and randomized control trial evidence, which has guided that. Some has been adapted from our previous trials, like the SMILE trial, which Tithiana will speak to next week, and also some of my previous work in diabetes prevention using lifestyle approaches as well. I think a noticeable difference from a conventional chronic disease management approach is that weight loss is not a target. And this is largely because what we found through our SMILES trial, Mediterranean diet as a therapeutic target for depression, was that the effects of the diet on depression outcomes were totally independent of any weight change. So it's much more about nutritional adequacy rather than caloric restriction. Now, the grey boxes are lifestyle targets that individuals can incorporate into their goal setting if they choose to or if it's appropriate. And further tailoring of the groups and the contents. So this kind of forms the basis and the foundation of the structured manualised programs, but co-facilitators of both groups also have access to each participant's social needs assessment that's done at baseline, medications, comorbidities, treatment expectations, their motivation and readiness to change, and any psychiatric illnesses as well. And then facilitators, the whole idea of the group setting is not only, I think, in real world practice, this can be much more cost efficient. And it can also, obviously the remote approach can allow individuals who perhaps live in more rural and remote areas that don't necessarily have access to this type of specialised care to receive that. But the group setting is really designed to create an environment of peer learning and peer support so that participants can provide each other feedback. But of course, the clinicians are there to use appropriate behaviour change strategies and evidence-based best practice in there from a dietetics and exercise physiology point of view and sort of keep things on track. But that from early reports is really working well for quite a number of the participants, not everyone, but the feedback that we've received so far is that it's something for participants to look forward to, particularly where they're quite socially isolated. So what have we found so far is that the demand is high. So we know that in a small regional town like ours, a population of about 300,000 people, we're getting about 12 referrals a week. And of those, we're seeing quite a wide range of, I guess, mental health profiles. So we're getting probably, we've had 76 here come from our local mental health service, and then a larger majority just coming from the community. So a lot of those 76 are individuals who have quite complex mental disorders, might be comorbid with a serious mental illness. They might have a long history with the service, whereas a lot of the community-based participants who are coming through may not have ever sought help before for mental health, not even conceptualize that they have a mental health issue. They just report, I just don't feel myself. So they're just seeking help for the first time. What we found from the, this is a little bit old because we've actually enrolled now 104, a randomized 104, and of that 104, the vast majority are women, so about 80% are women, and they are largely under the age of 50. So I think when you consider how other, perhaps some of the psychological models of care, like the impact model to which I referred before, you recall that I said that approach didn't necessarily have cardio prevention outcomes in favour of women, but it certainly did in men. So, I guess the early indication is that uptake of this program, it's quite popular for women. And so I think that that's important, but also to consider the observational evidence, as we just saw before, that diet may be potentially a stronger mediator in the depression cardiovascular link for women more so than men. It's a possibility, but also the meta-analytic level data would tell us that not only do dietary interventions appear to be a bit more popular in women than men, but the efficacy or treatment effects look as if they are a bit stronger for women than men. So there is the, I guess that's one thing that we can examine going forward with this trial. Unfortunately, I don't have any treatment data to show you, or any results data to show you today, but I would love to come back once I do, in the second half of next year, and share that with you. So in summary, mental illness is intimately linked with cardiometabolic health. Dietary approaches to their care are likely to provide mutually beneficial effects, but we just need more data, because so much of the existing evidence is either just limited for the reasons that I've said, or poor quality. We need more data on the effectiveness of diet in comorbid depression and cardiometabolic conditions as well, which I think is quite an untapped area. And I guess we'll know more after the CALM trial is finished about the role of lifestyle medicine more broadly, and if that can alleviate depression and cardiovascular risk in the future. So for anyone who wishes to learn more about these topics, here are two articles, one of which is on lifestyle in serious mental illness by our colleagues, Dr. Joseph Firth and team, by way of a Lancet Psychiatry Commission, providing a blueprint for protecting physical health in people with mental illness, and really drilling down on what can we do to reduce that mortality gap that exists. One of the blueprints, that the ideal model that they suggest, is a structured lifestyle-based, in sort of lifestyle intensive approach that was used in the diabetes prevention projects to which I referred earlier. The second article is a commentary that I and others in the team wrote, and both of these articles have argued for the dual benefits of a lifestyle approach to treating the physical disorders in order to address those mortality gaps for people with mental illness. This one on the right here was much more focused on common mental disorders and arguing that really it could fall under the same umbrella as other non-communicable diseases because of the shared pathways and risk factors, high levels of comorbidity and intricacies that do exist. So, but I think the upshot is that I do really feel, and I think my colleagues share my enthusiasm, is that it does feel like over the last sort of 12 months or so, there's been a real momentum shift in this area, and there's a lot of appetite to start embedding lifestyle-based mental health care into real-world practice. So I do think it is a time to be sort of enthusiastic. For those clinicians in the audience, of which there are obviously many who are interested in learning more about the evidence-based key recommendations for how you would go about enacting this type of care in practice, I am currently co-chairing these international guidelines that will be published in 2022. So please do keep an eye out for those, because the whole idea is that they are designed, this is a global task force, they are designed to be used across any setting. So yeah, probably, hopefully by mid next year, if not earlier, these will be publicly available. And of course, as Dr. Subhadra said at the beginning, Dr. Ox has done an amazing job at developing this free online course in food and mood that was rated the most popular course in our country in July. So should you be interested in enrolling, I would highly encourage this. It's a fabulous learning opportunity. So just finally, I'd like to acknowledge my funding body, which is the Heart Foundation of Australia and the Wilson Foundation, and of course to thank my colleagues at the Food and Mood Centre and Impact. If anyone wants to reach out to me, I'm happy to stay in touch via Twitter or via my email, and of course I'll be around after for the duration of this session to answer questions. With that, we'll leave it there. Thank you very much.
Thank you very much, Dr. Adrian and Dr. Tithiana. It was wonderful listening to both of you, two different perspectives of mental health. And you have rightly started, Dr. Tithiana, with adolescence, the most important period in life, which will set actually a lay foundation for future health. So it was a right way to set the stage by you. And Dr. Edwin, you have correctly linked the mental health with the non-communicable diseases and really highlighted the points of links between food, nutrition, mental health and non-communicable diseases. And both of you have supported the information that you have shared with very strong scientific evidence. And all the meta-analysis reports that you have shared are very interesting reports, and worth each one is so much interesting that you have to literally go through each and every report to understand the overview or the conclusion from those reports. It's really wonderful listening to both of you. And of course, Dr. Tithiana has offered to moderate this session, but I feel both of you have a lot of questions. And as we have shared, we have invited questions right at the stage of registration for the webinar. And we have received quite a few questions, and some of them you have tried answering during your presentations itself, since we have shared them with you. But there are few of them which are more of relevance to our country, probably that is why we want to take it up once again. And since the questions are more, I'm inviting even Chandni to participate in the moderation, so that if I miss out on any question, she can also take it up. And she's, as you know, she's very, very enthusiastic in this area. So she may be having even her own personal questions as well. But of course, we give due importance to the questions that we have received from the participants. So initially, I was thinking of actually summarizing what you spoke, but now I am actually not doing it for the time constraints. We need to better take up the questions rather than summarizing what you spoke. We are anyways going to meet again on 20th, so we will take up some more details on that day as well. So that takes me to the first question. So firstly, I would like to invite Dr. Tithiana. One second. Yeah, Dr. Tithiana, this first question is actually for you. This is very, very relevant to our scenario in our country and most of the developing and underdeveloped countries. The food insecurity is a big problem. Okay, and majority of the population are facing this kind of problem, and it's very very strange situation in the sense the insecurity is there. Nutrient insecurity, I think we should put it from that angle also. It's there both it's there across the income groups. It's not only in the low socioeconomic groups. Food insecurity or nutrient insecurity is there across the income groups. So in this kind of situation of food insecurity, or maybe due to unaffordability or poor food choices, etc., how to manage the food, and can you throw some light on this? Your opinion, now, is it possible? Is it still possible with the limited resources to connect food to mood?
Yeah, it's a very good question, Dr. Subhadra, and thank you for asking it. It's a very challenging question, of course, because food, when we don't have access to food, it becomes problem. So that's why in general, when I personally talk about food, I try not to label food as good or bad, because in any life situation, for people who don't have access to food, any food is a good food. So I mentioned with children and young adults, we see consistently that breakfast, for example, breakfast consumption being linked to better academic performance. In this instance, any food would be better than no food. Quite often we see in developing countries, or it's in all other countries, and I've been answering these questions in a chat as well, in a private conversation with some of the participants, we see that our food environment dictates our food choices. This is why it's quite important to educate young people about their food choices. Even in the most challenging situation, usually in Australia, I understand there's a government support programs which would help to the extent with provision of food. Unfortunately, they're not always available for all people, but for us, as dietitians and nutritional specialists, it's part of our profession to advocate government and local government bodies for provision of food programs. For example, in Australia, in low socio-economic areas, we see that children receive regular breakfast at schools. So if something like this is possible in your area of work, understanding and providing information to people about this would become quite important. But look, it is quite challenging when there's no resources, of course.
Yes, yes. Actually, I'm very happy to share with you that Indian government also has many programs to benefit the underprivileged sections of society. So there is food offered to children, children, pregnant women, etc. Through the systems, the various systems are there. Through them, there is food distribution system here in India as well. And government is trying its best to take care of the food insecurity first. And through that, there are several programs of food fortification, etc., through which they are going to increase the nutrient density of the food and provide that nutrient dense food to the to the children or vulnerable groups, so that they can maintain this, they can take care of the nutritional situation of the country. So through National
Absolutely.
Nutrition Mission, there are several attempts made by the governments across the country, and there are several beneficiaries of these programs. So the attempts are being made.
It's fantastic. But also, Dr. Subhadra, if I can go back to what you mentioned about nutrient pool, what we see, unfortunately, that our food environment being overtaken by producers of ultra-processed foods. Quite often, it's what's available, particularly for younger people who prefer to eat outside of home. This is where education becomes quite important. If we explain to people that quite often those companies which produce those ultra-processed foods, people who are in charge of those companies don't eat those foods because they know they're not particularly good when it's come to nutritional values. So maybe highlighting, there was very interesting experiment done in American school where children, so teenagers, were exposed to the truth about food production and ultra-processed food production. And they've been shown that executives of those food producers don't actually eat that food, and they pry on people who don't have enough knowledge or who don't have enough resources to choose a better food produce. And it's interesting how it's actually impacted the knowledge of teenagers, but then also impacted their food choices. So shining the light and not being afraid to expose food producers, some of the food producers, for what they are. They just there to benefit their outcomes and their bottom line, their bottom dollar line, and not health of the population. So explaining what better food choices could be made becomes quite important.
That's a very valuable point, Tithiana. You have really brought it out, because across the income groups, as I have been stressing on this, across income groups, because what is making a difference in what one eats is the food choices, right from childhood to adulthood also. And of course, the children and youngsters are more vulnerable to that, those kind of publicity, or when you said using these actors or role models, etc. Because themselves, if they are advertising for wrong foods, then it becomes very difficult for parents and even educators to divert the attention of children and focus, teach them the good food choices. That's a very important point that you have brought.
Yeah.
Thank you so much.
But also what we see quite often, ultra processed foods become very safe food to consume, because you can't really get food poison from ultra processed food. So I know sometimes in the countries, in my home country, so I'm originally from Ukraine, people on the street buy ultra processed foods because they know it's safe.
Yeah.
It also comes from the lack of knowledge of how to prepare and care for the food. So it's going to become a safe choice to eat. So it's all about education and providing people with choices.
Yes. Actually, nutritionists in our country are making the sincere efforts towards educating the youngsters towards better food choices. Thank you so much, Tithiana. And now I want to bring in Adrian also into the discussion through this question. See, it's very common to observe post-delivery stress, stress or psychological stress among women after delivery. So there is a question related to that, are there any specific foods to combat post-delivery stress? Or even, of course, I thought another question is somewhat linked to this only, how to manage post-menopausal depression and mood swings. Can you throw some light on this, Adrian? Since you are from clinical background, so I've thought of segregating the questions which are having clinical aspects into it, and I'm planning to pose those questions to you.
Yeah, sure. So I think the one of the key issues, particularly from a cardiovascular point of view, is that the difference between the trajectory of illness for women and men is the fact that women have been, I guess, considered to be largely protected because of their elevated estrogen levels compared to men from having a heart attack, at least delayed by about 10 years. So once they hit menopause, I guess the issues around the cardiovascular risk as it relates to drops in the estrogen levels, but also through the use of things like hormone replacement therapies, means that the role of a cardioprotective diet to potentially offset any of that elevated risk then becomes very important. So, I would defer to Dr. Rox to speak to the specific needs of particular nutrients for in the postmenopausal period. But just to say that there's a significant sort of reversal, and we're actually finding that women are starting to have, and this is across the world, but particularly in countries like the United States, women are beginning to have heart attacks at a younger age, which then that whole idea of them being delayed in their clinical manifestation of heart disease by about 10 years, that gap is getting shorter and shorter. And when you start to look at the mental health profile of young women, premenopausal women, particularly between the ages of about 35 and 54, they're actually beginning to, in the US, their mortality rates owing to cardiovascular disease are actually increasing, which is quite unprecedented. So it's only when and it doesn't seem to be explained by specific factors like, BMI, BMI or diabetes or anything like that. That plays a role. So if we start to look at some of the broader stressors on women, things like living in single parent households and raising children, and I suppose this is where my training in sort of family violence and other stressors seem to be becoming more elevated for younger pre-menopausal women in the current context. Some of that is to do with socioeconomic conditions. And I think the way that COVID plays out with a lot of the economic and broader mental health implications, I think women and young people will be at very elevated risk there. So I guess the short answer is to say that based on that sudden sort of reversal of cardiometabolic risk in the peri and postmenopausal period for women, that, those cardioprotective diets, and as Tithiana said, there's no one prescribed, but the evidence base does, of course, tell us that anything that is plant-based Mediterranean diet with very good quality fat oils and fishes is going to be of benefit. Tithiana, did you have anything to sort of add to that in terms of nutritional profile?
It's pretty good. It's pretty good coverage. Thanks, Adrian. We do have few studies showing that mother's diet all during pregnancy leading to delivery. So again, we see that direct correlation between better diet quality and better mood in mothers post-delivery. But the bottom line, mothers need support. So that's probably the best indicator and biggest contributor to their mental health. It's support post-delivery, because, I don't think anything could prepare mothers for, for those stages after delivery. So support, regular meals, having someone to actually give them water while they're feeding children and becoming dehydrated, all the little things, basically. That's what most important.
Thank you, Tithiana, and thank you, Adrian. Now I invite Chandni with her question.
Thank you so much for giving me this opportunity, Dr. Subhadra, and congratulations to Dr. Tithiana and Dr. Edwin. Such an excellent talk. It was extremely enriching. Dr. Tithiana, one of the questions that I have from the participants is, you spoke about eating disorders and how it is very common, especially for adolescent girls, to suffer from eating disorders and emotional eating. So the question one of the participants has asked is, how can we prevent eating disorders, or how do we tackle emotional eating? So if you could throw some more light on that.
It's actually a very interesting question. Thank you for asking, Ms. Chandni, and very challenging too, because we need to sometimes separate here what we're trying to achieve, because emotional eating is quite normal in humans. It's a normal kind of reaction to stresses for people to eat and comfort and soothe themselves with food. So again, maybe unpacking the stresses and trying to understand why emotional eating is there in the first choice could be quite helpful. For this, of course, we need support from multidisciplinary team, because dietitians and nutritionists, although have some psychological training or psychotherapy training, we do need support from psychiatrists and psychologists, counselors, to understand where their emotional eating stems from. If it's just something as a behavioral habit, because a lot of us do have that as a behavioral habit, suggesting other habits and providing gentle, very gentle opportunities and alternatives to change emotional eating, to say, phone discussion with a friend, or chatting with your friends, going and seeing movies, or doing anything else, just shifting the focus away from food as a soothing factor is quite helpful. But we need to be careful, and I mentioned eating disorders because a lot of eating disorders develop during the earlier adulthood and the teenage years. So not focusing on bodies, focusing more on health, say gut health or mental health, is quite important, because kids, I mentioned, all girls, they all growing during this age. So all girls want to be smaller, all boys want to be bigger. So making sure how we deliver message and explaining that bodies come in all different shape and sizes, and it's absolutely fine, is quite good. That's why we think working and focusing on gut and mental health, it's much more inclusive message, because we don't target people based on their body size. We talk about mental health and gut health. So this could be a nice way to discuss diet with young people.
And I think I could just add about the sort of emerging condition of orthorexia as well, which probably is something many of you are familiar with, but to, I guess, just consider the complexities of a disorder where there is quite a sort of compulsion, obsession on that sort of healthy eating, as it were. So thinking about the role of disordered eating beyond, I guess, what many of us either receive training in, or perhaps more of an awareness around sort of bulimia and anorexia. But I can also comment on the fact that as part of our CALM trial, as our only real inclusion criterion is that individuals are all coming in at an elevated level of psychological distress, we have actually noticed a high proportion of individuals who are coming in with a history of disordered eating, which obviously is not uncommon in terms of a co-occurrence with sort of mental illness, and that a lifestyle-based approach hasn't always been helpful for them. So in a number of instances, we've had individuals who have decided to withdraw from the study because they have found it triggering, which, as we've seen from the data that Tithiana presented, there does seem to have been an increase in presentations throughout the COVID, particularly lockdown period, of sort of that re-triggering for many individuals with a history of disordered eating as well. But then on the flip side, we have had individuals who have remained in the program who are probably much more, what that distinction that Tithiana has made between a disordered eating from a clinical perspective, versus individuals who more fall into the category of looking for strategies like mindful eating that very much is applied in our CALM program, that works really well for them. So I guess it's about clinicians knowing when it is an individual who could benefit from those strategies versus an individual who could be very triggered.
Absolutely. I'm sure the participants' question has been answered, and I truly agree that mindful eating is something that we are also bringing in. And I'm happy to share that at Nirmala Niketan College, where Dr. Subhadra and I teach, we have a subject called food psychology. So we teach them about how to promote aspects of positive body image. So body shaming is something that most the adolescents go through. So something that I think positive messages need to be sent across board on that aspect, and as well as talking about more from the aspect of how to inhibit emotional eating, rather than focusing on that, really focusing on mindful eating. So what is mindful eating? Not eating with respect to cues of your emotion, not eating when you're bored, like you said, like Dr. Tithiana said, rather spending that time watching a movie or talking to your friends than finding comfort in food. So these are the kind of approaches. We also call it the holistic approaches to nutrition. We are using it in India, especially with the adolescents. These techniques work wonderfully because, rather than just telling them what not to eat and what to eat, you are engaging with them in a behavior change aspect, where you're telling them, eat mindfully, don't eat when you're bored, listen to physical aspects of hunger, not just emotional aspects. So I think that approach can be quite helpful, especially not only with adolescents, but working with adults, in improving their diets, and of course, in turn, helping them improve their mental health. So I think that's very insightful. And Professor Adrian, another question that we have is very interesting, and the participant wants to know your view regarding, is garlic really helpful in treating Alzheimer's?
Is garlic?
Yes.
I think I'll have to defer to Tithiana on that one.
Yeah. Actually, even I want to come in. I remember asking Tithiana this somewhat similar question in one of the previous sessions which she has taken, because India is very famous for its spices and condiments, and we are regular users. And now globally, the spice usage has increased in COVID situation as well. So many spices and condiments that have had proven benefits in various degenerative diseases as well as mental disorders as well. So this question often comes up, like, are there any kind of spices or condiments which have proven benefits in Alzheimer's? Tithiana, have you come across any such kind of information?
I can comment in general. In my understanding, there's not enough research which focus on specific food and impact on specific food on specific cognitive or neurodegenerative outcomes. What we understand is some factors in food might impact the outcomes, such as polyphenols, or for example, lots of spices have a lot of polyphenols, or even simple fiber. So if it's plant-based food, it's a simple fiber and microbe available fiber. So I will talk about that next week and draw the link between specific components and food and how they might impact our cognitive and mental health as well. But in general, it's not food itself, it's what food actually contains.
Yeah, and I think that is an important point. I mean, we do have a colleague at our centre by the name of Dr. Wolfgang Marx, who has done a number of meta-analyses looking at particular spices like turmeric, for example, on cognitive outcomes. But I would echo what Tithiana said. I mean, I think the one thing that we are perhaps trying to get away from is talking about really specific, sort of whether it's superfoods or what have you, because we know that it's the Mediterranean diet, for as one example, is much more of a lifestyle, and that's certainly the approach that there's a lot that goes that that can produce benefits owing to diet that goes beyond particular, whether it's micronutrients. And a very famous nutritionist in Australia would, has long argued that you're not eating a micro or macronutrient, you're eating a whole of diet. So I would echo what Tithiana said, but if you are interested in learning more about the evidence on particular spices, then I would recommend looking up Dr. Wolfgang Marx.
Yeah, thank you, Adrian, and thank you, Tithiana. Actually, here I would like to take you a little away from these kind of dietary patterns or dietary composition. There are actually two interrelated questions. One is specific to serotonin. Okay, it is much discussed whenever there is a discussion going on mood. So, any diet that is specific to increasing the gut serotonin production. And a somewhat relevant question is, are there any mood elevating food options for adolescents? So I request Tithiana to come in, and then Adrian also can throw some light on it.
But again, and probably I do apologize if my answers are a little bit boring, but I don't go into specific foods, and I more talk about in general dietary patterns. So serotonin, of course, very important for our mood. We understand that there's some associations between certain diets and production of serotonin, and we understand that diet quality usually have something to say about all these other systems in our body which could be linked to mental health. So in general, good quality proteins, and that's what we see, good quality proteins can come from animal, but also plant-based source. So proteins which comes in beans and tofu and legumes are excellent for this too. So for adolescents, regular meals, which will be adequate for their energy and protein needs. So if it's a growing bodies for boys or girls, regular meals with enough energy is a great start. And reducing the calories which come from soft drinks, which usually are very energy high and very nutrients poor. So we need to make sure that whatever adolescents consume is actually high in good nutritional energy.
So I would just add to that by saying I think that the question is really getting at the mechanisms of action which might drive good mental health outcomes owing to a particular diet. And because I think that perhaps a lot of people think that the evidence base is perhaps more vast than what it is, because at the moment, with 3 reasonably small clinical trials in this area, albeit they've been seminal and definitive in nature in proving the concept, there's a couple of shortcomings. And one is that because they are so small, we can't really at this point in time determine the mechanisms of action, whether or not it's driven by gut or serotonin production or whatever it might be. And the other factor is that I know that with our SMILES trial, which was the first of the 3 to be conducted, that 60% of individuals in that sample were on some form of SSRI. So it makes it extremely difficult to disentangle, because ethically we can't really ask people to stop taking their medication in order to be involved in a study of a diet that's unproven. So it does make it very difficult with just 3 small studies until we start to conduct much larger studies or pool studies to understand the mechanisms of action or to personalise such care, so that you might be targeting an individual that has particularly low serotonin or particularly, whatever the clinical profile might be, in order to receive a particular diet. That does seem to be a long way down the track. Having said that, knowing a bit more about expanding the evidence base to lifestyle-based mental health care, we know much more about exercise and the sort of the serotonin generation that goes, and dopamine and things that go along with particularly high intensity exercise. And because there's just been so many more randomized control trials looking at the effects of exercise on a whole range of different types of mental health outcomes, we can just understand these sort of mechanistic questions a bit more. So my advice would be to, I know that it sort of sounds, as Tithiana said, it sounds quite frustrating that we're giving quite boring answers. We'd love to say, yes, that is absolutely the mechanism. But, you know, stay tuned. There is a lot of new studies that are going on in this area. So I'd really hope that within time we can answer some of these unanswered questions.
Yeah, I think probably in the next session, Tithiana can throw some light on this. Probably the question is hinting at the gut-brain axis and the impact of gut microbiota on the tryptophan metabolism, tryptophan serotonin metabolism. And probably in the next session, you can throw some light on this.
Yes, I will make sure to cover that.
Yeah. So based on that, like, you know, the way how it can be improved, that the brain availability of tryptophan could be like, you know, facilitated, and thereby the elevated mood can be maintained. So yeah. And Chandni, do you want to ask about the data collection part of it?
Yes. So, Dr. Tithiana, this question is with regards to the methodology that we adopt to, conduct these studies. And of course, we know that, there are food frequency questionnaires and 24-hour recalls available to collect data from, I'm asking specifically in context with youth, but in the actual scenario, sometimes it becomes quite difficult because there are a lot of difficulties or limitations when you're working with adolescents or young people. So light on what are the most robust methods for dietary data collection when we are conducting such studies, in relation to finding associations between diet and mental health.
It's a very good question. And look, measuring dietary intake is one of the largest or biggest challenges in diet-related interventions and studies, because people quite often don't report what they eat, and they, report what they don't eat. So usually when we try to assess somebody's diet, for me as a dietitian, it becomes quite challenging when people come and say, oh, can you recommend very short, very easy questionnaire which will collect data on dietary intake? There's no such a thing. So usually to have more or less kind of better understanding of dietary intake, we need, pardon me, we need at least 2 different methods of collection. So quite often we use food frequency questionnaire to get more habitual dietary intake, to understand how people usually eat, because we're looking for these dietary patterns over a longer period of time, such as months or year. And food frequency questionnaires could be used by participants themselves, or for younger children, we ask parents to complete these food frequency questionnaires. And then we also ask people quite often to do something like complete 3 24-hour recalls, and there's good tools online and free tools which you can use for 24-hour recalls. So you need at least 3, 2 from weekday and 1 from weekend, or provide weight food records. So when we ask people to weigh and record everything they consume. But as you can imagine, for some reason, food becomes with a lot of stigma and a lot of shame attached to it. So quite often people underreport or overreport their intake. So I can see I'm working with people with restrictive eating disorders. They quite often overreport their intake. They talk about something they have not consumed. So look, it is very challenging. There's no perfect tool. There's some advances in technology which assesses dietary intake by measuring how many times people chew, or by having a little cameras attached to them. But it's not particularly easy. Best way if we work one-on-one as practitioners, not as researchers, it's to develop that rapport with our patients and our customers, so they feel free to share what they're actually eating with us. That's probably the best thing to do.
Yes. So I'm very happy to know that all of us are in the same line, because most of the nutritionists are facing same problem, and we are trying to tackle it out in the same manner how you said just now. Dr. Adrian, I had one question which is very relevant to current population. We have increasing incidence of hypothyroidism these days, and PCOD is also there. And PCOD is, of course, more relevant to the youngsters. And the hypothyroidism is also being noticed right from childhood. So these patients of hypothyroidism actually often are found with depression or some kind of mood disorders. So, what is your opinion on that?
It's definitely not my area of expertise, so unfortunately I can't comment. I can do what I can do before my next session. I can try to find some kind of paper or some kind of evidence to provide, but I won't be able to unpack or provide my opinion on this, unfortunately.
Yes. And in any point to contribute, Dr. Adrian?
No, I mean, I don't have any expertise.
So we'll wait for the next session. No problem.
Yeah.
We'll wait for the next session. Similarly, there is another question. If you want to hold it for the next session, not an issue. That is suggesting dietary choices or intakes for hyperactivity children.
Yeah. So that was something that we covered in the systematic review that Tithiana presented, which is a little bit outdated, but it looks like it's just now been updated most recently in 2021. And we, at that point in time, we were largely focused on internalizing disorders and the relationship between dietary patterns and internalizing disorders, although it is difficult to I guess, break down the two. So I would point everyone in the direction of that 2021 update, looking at, that has systematically reviewed the evidence to look at the relationship between dietary patterns and externalizing disorders, because I've got no doubt that the evidence has come on since we conducted ours back in 2014, I think it was.
Okay. Yes, I have seen that report which Tithiana has presented. Yeah. Because this is one of the upcoming problems actually being identified in more and more children nowadays, and probably, as you said, it is a combination of even social situation and family situation. It's not always only food that need to be blamed for some of these problems, but however, it is interesting to know from your evidence that you have presented, Tithiana, about that internalizing the symptoms, and so that is something good, probably, because there are some opinions by experts, high sugar intake, sweetened beverages consumption. These are more associated with hyperactivity in the children. So probably once again the same kind of dietary principles do apply over here also, along with the behavior modification, as we have been discussing about it. So that brings us to the last question, Tithiana, for today. Are there any dietary allowances for individuals with depression? Is there any difference in the dietary allowances or dietary nutrient allowances for individuals with depression?
Look, I think for dietitians or nutritionists working with any patient, be it with nutrition, with depression or any other chronic disorder, fixing any nutritional imbalances become quite important. So we can see, for example, in younger females, low iron levels might lead to lower mood because they usually people feel more tired, and of course they're going to feel more low mood. So looking at blood tests and seeing how we can fix, preferably with food, any nutritional imbalances would be important step. But in general, it's more taking that more holistic approach and looking and remembering that diet is just only one modifiable factor in this multiple factors which might impact our mental health. So yes, check for any imbalances for low levels, particularly iron in females, but in males as well. And then, yes, see how you can correct this and then focus more on holistic approach.
So while planning the diet for these individuals with depression or mental disorders, you are still following the recommended dietary allowances. Okay, and
Yes.
correcting the nutritional imbalances. And then within that, you are trying to make your recommendations in the form of dietary guidelines. Am I right, Tithiana? That's
Yes,
what.
yes, absolutely right. Yep.
Thank you so much, Tithiana. Yeah, Dr. Edwin, you want to continue?
Yeah. So, I mean, my comment on that would be to, I think, alluding to what I said in my presentation around the whole, I guess, understanding now that depression is an inflammatory condition. So if there is sort of elevated general inflammation, but also oxidative stress and free radicals and things, then the idea that anti-inflammatory properties that exist and can be promoted with, from a diet that is, rich in healthy oils and all of the things that we've mentioned, then I think that absolutely makes sense. And then we've just released it or published a paper in the last week or so that demonstrates how we might go about adapting some of the principles, the dietary principles specifically, from other chronic disease prevention programs that have proven to be very effective for, say, preventing diabetes. And the key principles and goals and objectives of those, some of which are shared, of course, things like lowering saturated fat, increasing fiber, for example, all, sort of apply very well here. But then there are things that are not shared, because that's where the evidence-based in nutritional psychiatry and lifestyle psychiatry is at the moment. And one of those, the obvious one that I mentioned, was a weight target. So reducing weight by about 5% in individuals who have pre-diabetes is a very powerful, through diet and exercise and weight loss, is a very powerful way of reducing and maintaining that reduction in incidence of type 2 diabetes. But we just haven't found that same principle exists for the benefit of mental health. Now, what's to say might happen as the field advances, but again, I would encourage anyone that's kind of interested in unpacking how these programs might be the same or differ from more of the conventional programs that we're used to using in other areas of medicine and dietetics.
Yes.
Yeah.
Thank you very much.
I'm just gonna put sorry, Dr. Subhadra, I'm interrupting you. I'm putting the link to that article Adrian mentioned. It's just been published in Nutrients, and that's open access, so anyone can have a look.
Thank you so much, Tithiana. Thank you so much. Adrian, you are very much right, very right in saying that the chronic degenerative diseases which people are already suffering from, or they're heading towards that. So that is already pre-existing condition. Then over and above, you have superimposing factors. So it is like becoming ultimately a cumulative consequence of all of them. Like the mental health status is becoming a cumulative consequence of all these. So obviously the ones who are more prone to the chronic degenerative diseases are at higher risk of mental disorders. So it's a very complicated situation actually, and very interesting area to study. Both your presentations have brought into light so many areas that lacunae that need to be filled in through research. So that really invites research, and so many nutritionists need to be as a team, medical nutrition psychiatrists from the field of psychiatry, all experts as teams should get involved in that kind of research to bring in more and more input, so that we will be ready with better dietary guidelines from our capacity as nutritionists. Thank you so much, Tithiana and Adrian. We'll be looking forward for the 20th session. Once again, it will be definitely very, very benefiting to all the participants. So with this, we'll close the session, but I'll invite Chandni to make certain announcements for today.
Thank you so much, ma'am. So on behalf of the Nutrition Society of India, Mumbai Chapter, I take this opportunity to personally thank our chapter convener, Dr. Subhadra Mandalika, for taking a keen interest in not only leading, but also encouraging our team to organize this 2-day webinar on this pertinent topic of role of diet in mental health. I'm also extremely thankful for Dr. Tithiana Rocks and Professor Adrian O'Neill for accepting our invitation and lucidly presenting and providing great insights regarding the role of diet in relation to mental health and throwing light specifically on a crucial life stage of adolescence. Thank you so much, and we are looking forward to listen to you on next Saturday as well, on the 20th. And before we officially close, my sincere apologies to the participants because we overshot a little bit. But as you can see, we are so passionate about this topic, and we could continuously go on talking about it and discussing it in greater detail. I would just like to make a few last announcements regarding the certificates, because our participants are quite keen to receive these certificates. Thank you, Neha, for sharing the screen. So in order to receive the certificate, it is compulsory for you to fill the feedback form, and you have been provided with 2 feedback forms for each of the sessions, which is 13th today and 20th on next Saturday. We have 2 different feedbacks, and you are required to fill both the feedback forms in order to receive the certificate. And certificates will only be sent after the second webinar is over, that is on 20th November, Saturday. So please do not email us before that, asking us regarding certificates. You will definitely get them after the second webinar is over. The feedback form has already been sent to you in the mail where the Zoom link was sent, and it will be activated after this session is over at 2 p.m. and it will remain open till midnight tomorrow. So sincere request for all of you to please kindly fill it, as your feedback is really important to us. And please don't forget to join us for the second session on 20th November using the links that have already been sent to you. And we'll be seeing you at 11 a.m. on 20th, that is next Saturday. Thank you so much for your patient hearing. And thank you to all the speakers once again, and Dr. Subhadra for our excellent moderation. Have a great day ahead. Thank you.
Thank you so much. Thank you, Tithiana. Bye.